Good to be here and join you this morning. So I'm the non-surgeon on the panel. I'm what's called a physical medicine physician. I'm board certified in physical medicine, so I see patients before, during, and after their time of surgery. We're talking about knee and hip and knee arthritis, which is a very common problem. We have over 30 million Americans with joint osteoarthritis, and probably about 600 million worldwide. But in the United States, about 1 million people are receiving total joint replacement in the hip and knee, which means there's a whole lot of people who are needing treatment that is non-surgical. So my job is to provide the best non-surgical care I can provide. As you heard earlier, there's great recommendations for exercise, physical therapy. Occasionally, steroid injections can provide temporary relief, or gel injections can provide temporary relief. But in my practice, and I've been doing this now for about 25 years, had a whole bunch of patients who had not responded to non-surgical care, but were not quite ready for a surgical intervention. And the reason might be that they might be too young. Actually, last week I saw a lady in her late 40s who has bilateral bone-on-bone knee arthritis. This is becoming more common occurrence these days. The patient's arthritis may not be severe enough to warrant a surgical intervention. Patient may be too old or too medically frail to undergo a surgical procedure, or that just may be their preference to avoid surgery. And basically, if the patient wakes up in the morning and is contemplating surgery and is doubting it, usually that means they're not quite ready yet. So what other options are emerging that might be of use for us? Well, there's a field that's emerging, as you heard, called regenerative medicine. Regenerative medicine is based on the premise that our bodies do have the capacity to heal themselves. And there are orthobiologics that are emerging as treatments. An orthobiologic is a cell or cell-based therapy that can be translated into a clinical application. Now, we would characterize these treatments as investigational. There is good support for many of them, but very preliminary evidence for some others. Nonetheless, patients are interested in learning more about it. So I'll give you a cursory review of some of the more common treatment options that are out there to review. So PRP, or platelet-rich plasma, is a treatment that involves using cells from your blood called platelets, and is based on the premise that platelets can provide growth factors which are helpful for alleviating symptoms of painful joint osteoarthritis. Secondary orthobiologic would be protease inhibitors. A2M is a molecule also found in the blood that has been shown to be helpful for cartilage health and for decreasing inflammation. Stem cells have become a household word, and stem cells come in many different types. Currently, here in the United States, stem cell therapy is only permitted through the use of what we would call autologous stem cell therapy, or using your own stem cells. These stem cells are found throughout your entire body, but they're most easily harvested from the bone marrow of the patient or from the adipose tissue of the patient, so in the form of a liposuction procedure, which, by the way, most people prefer over having their bone marrow harvested. But both are very rich sources of stem cells, and stem cells are desirable because they have many attributes that contribute to healing. Regenerative medicine, I told you, is based on this premise that the body can heal itself. These biologics can assist with reducing pain, reducing inflammation in the joint, improving blood flow, which is important for tendon and ligament injuries, protecting the cartilage for further degradation. Just as an aside, for years we were told that osteoarthritis is a wear and tear phenomena, and it's actually only partially true. It's osteoarthritis is actually a very complex chronic inflammatory condition where the cartilage is being degraded by molecules that are secreted by unhealthy cartilage cells. And so these biologics can help minimize that effect, as well as promote cartilage regeneration. So getting back to platelet-rich plasma, or PRP as it's commonly called, this has been in the published literature since 2006, when Dr. Mishra at Stanford published a study using PRP for tennis elbow, showing efficacy. But since then, there have been numerous studies using PRP for knee and hip osteoarthritis, as well as other joints in the body. And so much so that we actually have now level 1 evidence. We have dozens of prospective randomized clinical trials showing that patients can get significant relief of pain decrease in their inflammation for up to 12 months with a single injection. And the procedure involves drawing your blood, spinning it in a centrifuge, and you see there in that image the red blood cells have settled to the bottom. On top of there, a layer of white blood cells and platelets, and then above that, plasma, which contains electrolytes and proteins, and pretty much everything you had for dinner last night is floating around in that plasma, and your cells use those nutrients to regenerate themselves. So we extract the platelet fraction as well as some of the plasma and inject that into the patient. There's many different ways to combine these cells, and standardized protocols currently do not exist, but in the published evidence, there are good outcomes, and that's particularly true for the mild to moderate osteoarthritis. Not as helpful for more severe osteoarthritis. If you have more severe osteoarthritis, then you're probably going to go to some kind of therapy that contains different cells. So in particular, the stem cell has been shown to be very useful. This is Dr. Philippe Hernigau. He's an orthopedic surgeon in Paris, France. He's the godfather, if you will, of regenerative medicine using bone marrow stem cells. He has more than 30 years experience in the field. He initially started using bone marrow stem cells to treat fractures that would not heal, and then later began using his techniques for joint osteoarthritis. Last year, he published a paper, prospective randomized clinical trial, where he treated his patients who had bilateral bone-on-bone knee arthritis. On one side, he's a surgeon, so on one side he did a joint replacement in their knee. On the other side, he injected bone marrow stem cells from the patient into their knee and followed these patients for 12 years, which is pretty remarkable for a study to follow patients that long. And discovered that both knees were improved. Patients were happy with both knees, but 2/3 of the patients actually preferred the knee that had cells injected into the knee. Now, important point to make is that the protocol that he used is different than the protocol that your doctor down the street might use. So the details become significant, and so we want to make sure that the evidence is consistent with the treatment that you might receive. So for example, another protocol might use cells from your fat. So this is a procedure that I perform routinely in the office. On the left there's a manufacturer who makes a device that allows us to process the adipose tissue in a way that is compliant with current FDA guidelines for safety and also for prevention of disease transmission. And essentially the fat is washed and rinsed and resized. It makes it easy to inject back into a hip or a knee. And we've had very good results. I've been tracking my results for 3.5 years, and I'll publish later this year our results. But we have greater than 85% 85% response rate with significant improvement in our patients. And that can last for many years. Now, the problem when we inject these cells back into the patient, we don't have the ability to quantify what we're actually injecting. So it's as if we're giving a drug, but we don't know the dose of the drug. Well, a way to overcome that would be to process the adipose tissue in a facility that is FDA inspected and do this through an FDA clinical trial. So this new company, Personalized Stem Cells, will do that, where we will process the adipose tissue, count the number of cells, make sure that the product is sterile, and then this allows your physician or surgeon to treat you through these FDA-approved clinical trials, and we're looking forward to moving the science forward. So it's important to look at safety, efficacy, and durability. Patients always want to know, is this safe? There's very good safety data for PRP, bone marrow stem cells, and adipose stem cells. Patients may have pain or swelling for up to 7 days. Efficacy, I shared with you. Typically, patients who have very severe arthritis will not respond as well as the more mild, but we have treated patients with grade 4, which is the most severe category. But if the patient's unstable or if their hip is very stiff, they may not do as well with these kinds of treatments. The durability is quite good for the bone marrow and the adipose, where we have patients with many years of relief, but it's very likely that those treatments will need to be repeated at some point in their life. Just a quick warning, you've probably seen billboards and ads for stem cell clinics. It's an important point to make that this is a field of medicine that belongs in the realm of science to make sure that we are assuring safety and efficacy. It's misleading to say that we can find stem cells in a bottle, just inject them in your knee, and that's all you will require. So, for example, there are companies that will distribute umbilical cord blood or amniotic fluid or placenta The problem with this is that, first of all, the FDA does not allow that. You cannot receive cells from another human being. It's probably a non-issue because when you test these products, as Dr. Fortier at Cornell did, most of these products do not contain living cells. They contain dead cells. And furthermore, it's probably not safe. There was actually a recall late last year where 17 patients were infected with a contaminated product. So I just encourage patients to avoid these types of treatments at this time until further studies confirming that they're safe and effective are confirmed. And then on this last slide, basically to stay out of trouble, I put a list of things that you should look for and questions you should ask your physician if you're contemplating this kind of therapy. First of all, are they board certified in a profession that includes training, that physician actually knows how to examine you, how to offer alternatives and review those alternatives with you? A physical medicine doctor such as myself or an orthopedic surgeon or a sports medicine physician can do this. Are they board certified in regenerative medicine? There aren't too many of us. There's about 300 of us worldwide, but that number is growing. Are they using an FDA compliant treatment? Are they trained to do the injection under guidance with ultrasound guidance or x-ray guidance? Make sure that you get what's called informed consent, that you know that you have other options to review. And then finally, does the physician track their outcomes and present their evidence at conferences or in medical journals? Thank you very much.